Hello, I'm Dr. Gavin Sigle, Director of Education at MedStar Washington Hospital Center and Assistant Professor of Surgery at Georgetown University in Washington, D.C. I'll be presenting this lecture on sexually transmitted proctitis. I have no disclosures. This talk will focus on the different sexually transmitted infections that can cause proctitis. These infections include the more common causes such as chlamydia, gonorrhea, herpes simplex virus, syphilis, as well as the less common lymphogranuloma venereum and CMV. Sexually transmitted proctitis with inflammation of the rectal mucosa occurs from direct rectal inoculation of pathogens. Though this is often true, the diagnosis of sexually transmitted proctitis should not be excluded from patients who do not report a history of anal intercourse. It is very important to take a thorough history and perform a physical exam. At the end of this module, the listener should be able to diagnose and treat sexually transmitted proctitis, differentiate acute versus chronic management of sexually transmitted proctitis, provide appropriate counsel to patients with sexually transmitted proctitis. Neisseria gonorrhea is the second most commonly reported bacterial STI or sexually transmitted infection in the United States. It is most commonly found in young, sexually active adults, with 95% of cases occurring in 15 to 44-year-olds in 2012. The majority of rectal gonorrhea are asymptomatic. Specifically, more than 50% of males and up to 95% of females with rectal gonorrhea do not report symptoms. In addition, a large proportion of females with gynecologic gonorrhea will also be simultaneously diagnosed with rectal gonorrhea. It is thought that this is due to contiguous spread from the genital infection. Also of note, only 4% of women with gonorrhea will have anorectal gonorrhea as the only site of involvement. In comparison, 40 to 50% of men who practice anal receptive intercourse will have the anal rectum as the only site of infection. Neisseria gonorrhea is a gram-negative intracellular diplococcus and is one of the most common causes of proctocolitis. Though this is often asymptomatic, if patients present with symptoms, they will likely have mucopurulent discharge with tenesmus and pruritus. In addition, these patients may have occasional bleeding as well. On anoscopic examination, there will be yellow mucus discharge from the anal crypts when minimal pressure is applied to the external perianal area. During proctoscopic exam, there will be mucopurulent discharge extending less than 10 centimeters from the anal verge. In addition, these patients may have nonspecific proctitis presenting as erythema or irritation, as seen in the following slide. This image shows gonorrheal proctitis with mucosal edema, erythema, and whitish plaques. Gram stains of endocervical, pharyngeal, and rectal specimens are not sufficient to detect the infection and therefore are not recommended. Tests that are available and used to detect Neisseria gonorrhea include culture, nucleic acid hybridization tests, nucleic acid amplification tests, abbreviated NAAT. However, NAAT tests have not been FDA approved for use in the rectum, pharynx, and conjunctiva. Despite this, some laboratories have developed performance specifications for using NAAT with rectal and pharyngeal swab specimens, so these tests can be used to help with clinical management. Neisseria gonorrhea has developed resistance to the majority of antibiotics used to treat it, including fluoroquinolones. However, cephalosporins are still able to treat the disease. Cephalosporins are recommended by the CDC for treatment of gonorrhea in conjunction with either azithromycin or doxycycline to treat chlamydia as well. It's important to note that only 5 to 10% of patients with penicillin allergies will have a reaction to first-generation cephalosporins, and even less than that will have a reaction to third-generation cephalosporins. Therefore, the CDC recommends that only patients with severe penicillin allergies avoid ceftriaxone. For these patients, the CDC recommends treating them with 2 grams of azithromycin orally as monotherapy in conjunction with an infectious disease consult. Chlamydia trachomatis infection is the most common bacterial STI reported in the United States. The majority of rectal chlamydial infections occur in men having sex with men, abbreviated MSM. There are 15 serotypes, with 3, G, D, and J being the most prevalent in MSM. Lymphogranuloma venereum, abbreviated LGV, is an STI caused by serovars L1 to L3 of Chlamydia trachomatis. This disease occurs through anoreceptive intercourse and has an incubation period of 5 to 14 days. Prior to 2013, LGV was thought to be a, quote, tropical disease. However, an outbreak in the Netherlands in 2003 led to the discovery of multiple cases in the Western world. The majority of cases in MSM are caused by the L2 serotype. Non-LGV associated chlamydia infections of the anal rectum are often asymptomatic. However, when patients do have symptoms, they often include tenesmus, pain, and fever. Proctoscopy of these patients will show nonspecific inflammation, erythema, and injected mucosa, but these patients will not have ulcerations or abscesses. LGV serovars are invasive infections that can cause severe inflammation with systemic symptoms and often affects the lymphatic tissue. LGV infections present in 3 stages. The initial consists of 1 or more genital ulcers or papules. Following this, the second stage consists of unilateral or bilateral fluctuant buboes and anal rectal ulcers. The third stage of the disease consists of abscesses, granulomas, fistulas, genital elephantiasis, stricturing, and sterility. If a proctoscopic exam is performed in the first or second stages, it will show pronounced inflammation with hematochezia, ulceration, and friable mucosa. LGV can be distinguished from other causes of proctitis by the lymphadenopathy associated with it. The diagnosis of chlamydia is based on clinical judgment, epidemiological information and exclusion of other causes, inguinal adenopathy, and genital or rectal ulcers. Testing for Chlamydia trachomatis can be done using specimens obtained from lesions of swabs or bubo-aspirates. These samples can be sent for culture, nucleic acid detection, or direct immunofluorescence. In addition to these tests, PCR-based genotyping can be used to distinguish non-LGV from LGV serovars. However, this test is not widely used. Even with all of these tests, patients who present with proctocolitis, lymphadenopathy, and genital ulcerations should be empirically treated for LGV. Treatment for non-LGV chlamydia consists of dual therapy for chlamydia and gonorrhea. The dual therapy is 1 dose of ceftriaxone intramuscular and doxycycline twice daily for 7 days. For patients with LGV, treatment is doxycycline twice daily for 21 days or azithromycin once a week for 3 weeks. Granuloma inguinale, also known as donovanosis, is a slowly progressive ulcerative disease affecting the skin and lymphatics of the genital and perianal area caused by infection with Chlamydobacterium granulomatis. This disease is endemic to tropical and developing areas, including India, Guyana, New Guinea, Central Australia, and Southern Africa. Granuloma inguinale is not often seen in the United States. This disease can be caused by both sexual and non-sexual contact and is transmitted via contact with open sores. Symptoms of granuloma inguinale typically present 1 to 12 weeks after infection with the disease. Granuloma inguinale often starts out as a painless nodule that breaks down into a sharply demarcated ulcer with a beefy red friable base of granulation tissue. These ulcers can develop on the skin, genitalia, perianal area, upper buttocks, or lower legs. It is possible that these lesions around the anus may cause stenosis. In addition, granuloma inguinale is associated with increased risk of superinfection and co-infection with other pathogens, including HIV. Granuloma inguinale is difficult to culture. Diagnosis requires visualization of Donovan bodies, which are numerous bacilli in the cytoplasm of macrophages seen with Giemsa or Wright stain. Granuloma inguinale can be treated with doxycycline BID for 1 week or with trimethoprim sulfamethoxazole BID for at least 3 weeks. Patients with HIV and granuloma inguinale should also be treated with parenteral aminoglycosides such as gentamicin. It should be noted that these lesions in patients with HIV-associated granuloma inguinale may take longer to heal. Treatment of granuloma inguinale may also require surgery to correct disfiguring lesions or stenotic lesions. Syphilis is a systemic disease caused by the spirochete Treponema pallidum. The disease is transmitted when mucocutaneous syphilitic lesions are present. Though rates of syphilis are low in the United States, there has been an increase during the last decade, likely associated with an increase in high-risk behavior in the HIV-positive MSM population. Specifically, it was determined that in 2000, 7% of primary and secondary syphilis cases were attributable to MSM. In 2004, this number jumped to 64%, and in 2012, it was determined that 75% of primary and secondary syphilis cases were attributable to MSM. The presentation of syphilis occurs in 3 stages: primary, secondary, and tertiary. Due to the fact that most patients present with either primary or secondary syphilis, Those are the stages that will be discussed now. Primary syphilis in the anal rectal area presents as a painful chancre. This is in contrast to genital ulcers of primary syphilis that are often not painful and asymptomatic. Also, the chancre in the anal rectal area is often misdiagnosed as an anal fissure. The ulcers associated with syphilis are often broad-based, occur between the anal verge and dentate line, and are located off the midline. In addition to the painful chancre, patients with primary syphilis may also have discharge, urgency of defecation, and tenesmus. It is these symptoms that help differentiate it from an anal fissure. Secondary syphilis occurs if primary syphilis is left untreated. This stage of the disease is characterized by a maculopapular rash on the hands and feet. In addition, patients will often have systemic symptoms such as fever, arthralgias, malaise, weight loss, sore throat, and headache. Also, it is possible that a condyloma lata may appear and can be misdiagnosed as human papillomavirus. This is an image of a chancre in the perianal region associated with primary syphilis. This is an image of condyloma lata seen in the secondary syphilis. There are a variety of tests that can be utilized to diagnose syphilis. Due to the fact that each of these tests has limitations, such as false positives, it is necessary to perform more than one type of serologic test. Dark field microscopy can be used and will show corkscrew-shaped yellow-green spirochetes. VDRL, or Venereal Disease Research Laboratory, and RPR, or Rapid Plasma Reagent, are non-treponemal tests that can be used. In addition to the non-treponemal tests, there are treponemal tests including FTA-ABS, or fluorescent treponemal antibody absorb tests, TPPA, or treponema pallidum passive particle agglutination assay, various enzyme immunoassays, and chemoilluminescence immunoassays. All stages of syphilis are treated with penicillin G. However, the various stages have different protocols. Primary syphilis is treated with 1 intramuscular dose of penicillin. Secondary and tertiary syphilis, as well as patients with HIV and syphilis, should be treated with 3 consecutive doses of penicillin given at 2-week intervals. Patients that are allergic to penicillin can be treated with doxycycline twice daily for 2 weeks, or they can receive tetracycline 4 times daily for 2 weeks. Follow-up testing should also occur for all patients. VDRL or RPR should be repeated at 6-month intervals for 1 year for HIV-negative patients. HIV-positive patients should have repeat VDRL or RPR at 3-month intervals for 1 year. Herpes simplex virus is typically associated with vesicular eruptions near mucocutaneous junctions. Roughly 20% of Americans are seropositive for HSV2. The seroprevalence of HSV2 has been decreasing since 1988, with a seroprevalence of 21% in 1988 and a seroprevalence of 16.2% in 2004. Despite this decrease, most people with HSV2 will not receive a formal diagnosis. Traditionally, HSV1 caused cold sores around the mouth, while HSV2 caused painful blisters in the genital region. However, with the increase in oral genital sex, both HSV1 and HSV2 can be found in both locations. HSV proctitis is thought to progress from the perianal skin into the anal rectum and then the rectum. HSV proctitis most commonly occurs in immunosuppressed patients, such as those with HIV/AIDS, bone marrow or solid organ transplants, and those engaged in anoreceptive intercourse. Patients with HSV proctitis present with anorectal pain, discharge, tenesmus, or rectal bleeding. In addition, patients may experience difficulty urinating, sacral paresthesias, and temporary fecal incontinence during the acute phase of the disease. Patients will also have extreme pain and sensitivity during DRE or digital rectal exam and anoscopic exams. In patients with suspected HSV proctitis, the perianal exam is key to diagnosing the disease. Patients with severe cases often have perianal erythema and ulcerations, as seen in the following slide. In patients who undergo sigmoidoscopy, the physician will see acute proctitis with mucosal edema and ulcerations. In addition, in immunocompetent patients, HSV proctitis typically does not extend beyond 15 centimeters. This image shows HSV lesions around the anus. The gold standard for diagnosing HSV is the viral culture with zinc preparation. There are also HSV-type antibody tests that can be used to confirm the diagnosis. Treatment of HSV is often geared towards symptomatic relief using oral analgesics and sitz baths. Antiviral medications such as acyclovir, valcyclovir, and famciclovir can be used to decrease the viral shedding and reduce the symptomatic period. In certain situations, there are specific treatments. Patients receiving solid organ transplantation should be given prophylactic antivirals, as this reduces the incidence of HSV proctitis by 73%. Patients with AIDS who present with severe HSV should be treated with intravenous acyclovir. Patients who have frequent HSV exacerbations can be treated with continuous or episodic oral acyclovir. Patients with HSV should be counseled appropriately in regards to transmission and safe sex practices because though those symptoms may subside, the virus remains in the body for life. Here is a treatment algorithm and table of treatment options of various patient populations. Please take a minute to review this on your own. Nonspecific proctitis and colitis have been associated with HIV/AIDS. Also, the mucosal inflammation is associated with an increased risk of HIV transmission, and therefore it is necessary to appropriately manage proctitis in HIV patients in order to reduce the amount of HIV shedding. HIV infection causes minor alterations in the architecture of the villi that can lead to malabsorption of carbohydrates in the small bowel. In addition, cytokine activation by foreign antigens causes increased permeability, contributing to diarrhea. Also, HIV has amino acid sequences similar to that of vasoactive intestinal peptide, abbreviated VIP, and may lead to diarrhea by causing an upregulation of VIP receptors. This may lead to a pathogen-negative diarrhea. Patients with HIV/AIDS-related proctocolitis often present with nonspecific symptoms such as diarrhea and abdominal pain. These patients should have a detailed history with particular focus being paid to sexual history, travel, diet, and medications. Some antiretrovirals such as malfinavir and ritonavir can cause medication-induced diarrhea. In addition to antiretrovirals, other causes of HIV/AIDS-associated proctocolitis include opportunistic infections such as CMV, Cryptosporidium, Microsporidium, Mycobacterium avium complex, and Clostridium difficile. The American Gastroenterological Association has created guidelines for the evaluation of chronic diarrhea in HIV-positive patients. Their recommendations include stool samples for bacteria and parasites. If no infectious cause can be identified via stool samples, it is recommended that an endoscopy with mucosal biopsy be performed. Flexible sigmoidoscopy with biopsies for microscopic examination for bacterial and mycobacterial culture should be done. In patients where CMV infection is suspected, a colonoscopy, rather than a flex sig, is recommended because CMV often involves the proximal colon. If the previous studies do not reveal a cause, then an upper endoscopy with mucosal biopsies is recommended. Treatment is based on the cause of the proctocolitis. However, for pathogen-negative diarrhea, the treatment consists of rehydration, antimotility agents, and somatostatin analogs. Cytomegalovirus, or CMV, is a double-stranded DNA virus. It is often found in feces, urine, semen, and saliva, but does not typically cause symptoms in immunocompetent patients. When it does cause symptoms in adults, they typically present with mono-like syndrome with fever, malaise, lymphocytosis, and abnormal liver function tests. CMV-associated proctitis presents as a mononucleosis-like syndrome with rectal bleeding after anal intercourse. Endoscopy is useful in diagnosing CMV proctitis as it reveals rectal mucositis and ulcerations. Treatment for CMV proctitis is based on the immune status of the patient. Immunocompetent patients do not require antiviral medications, as most cases resolve spontaneously without complications. Immunosuppressed patients should receive antiviral therapy. CMV infection can occur along the entire GI tract. Patients often present with watery diarrhea, abdominal pain, and bloody stools. Endoscopic findings associated with CMV proctocolitis include punctate and superficial erosions, deep ulcerations, and hemorrhage. Biopsies should also be taken for histological evaluation. Histological findings associated with CMV include mucosal inflammation, tissue necrosis, vascular endothelial cell damage, and the presence of intranuclear and intracytoplasmic inclusions. This is an image of a CMV immunostained section. This is an image of a rectal biopsy showing proctitis and intranuclear and intracytoplasmic inclusions by H&E stained section under high power and C under low power. The preferred treatment for CMV-associated proctocolitis is ganciclovir. However, surgical intervention is needed when patients present with perforation, massive GI bleeding, or toxic megacolon. The surgery performed should include resection of the involved segment with creation of an end stoma. This talk covered a number of causes of sexually transmitted proctitis. When taking care of these patients, a thorough sexual history should be taken in order to help facilitate an appropriate diagnosis. In addition to the physical exam, anoscopic exams should be performed, and further testing, whether imaging or laboratory tests, should be directed by the patient's history, symptoms, and physical exam. In summary, I have provided this table for easy review purposes. I'll take a minute on each slide for you to review the contents. I'd like to thank the MedStar colorectal surgery program, as well as a few individuals who contributed content for this presentation. Their names are listed here. Thank you for your attention.